You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 3rd, 2023. This week, a possible major breakthrough in the thinking about diastolic dysfunction and heart failure with a preserved ejection fraction, MRI scans and cardiac devices, and the relationship between atrial fibrillation and dementia. First topic, boom, what a big finding. JAMA Cardiology has published a fascinating RCT this week. The MyPace trial leads me to believe that I, and perhaps the entire cardiology community, have been wrong about a core concept in cardiology, and for decades. Pause there, yes, turn down the pace of the treadmill, back off on the watts if you're on your bike. Seriously, my friends, this could be big. It's a story about heart failure with preserved ejection fraction and special kinds of pacemakers. First, some background facts, then the study, then the results, then the potentially massive implications. The study involved patients who had HFpEF, but who also had pacemakers that were capable of pacing the heart at a higher rate without creating RV-LV dyssynchrony. And that latter point cannot be underrated. These were not standard RV lead pacers. Now, this was a randomized controlled trial of patients who had HFpEF and a previously implanted pacemaker. One arm got standard pacing at a low rate of 60, like it is out of the box. The other group had a higher rate based on age, height, and ejection fraction. Of course, higher rates could sometimes mean more RV pacing, so that is why this study included only patients who had pacemakers such as CRT devices or conduction system pacing, or pacers that were atrial-based and RV pacing would not occur with a higher rate. Now, since this study was a single-center trial at the UVM, and UVM, University of Vermont, has been a leader in His bundle pacing, CRT, and left bundle pacing, I suspect most of their pacer patients have these sorts of pacemakers that could have their rate increased without causing more RV dyssynchrony. Now, before I tell you about the MyPace trial, let me give you some background facts. Background fact number one. Patients with HFpEF far outnumber those with heart failure with reduced ejection fraction. And almost everything studied in this space doesn't work, at least if you look at real endpoints like CV death or mortality, not silly heart failure endpoints like heart failure hospitalizations. And I say silly because heart failure hospitalizations represents only a small fraction of total hospitalizations in these patients with HFpEF. In other words, what I'm saying here is HFpEF is a major health issue. All right, background fact number two. The typical patient with HFpEF that I have in mind is an older woman who has a very small, stiff, hyperdynamic ventricle. The problem is not systole, it's diastole. I've always thought that such a stiff ventricle needs a slower rate, more time to fill. And I'm not alone. Others must think this is so too, because nearly all of the HFpEF trials enroll patients on beta blocker. I went back to look at 3 of the big ones, and all had more than 80 to 90% of patients in both arms on beta blockers. Okay, background fact number 3. When I looked into the supporting data for the MyPace trial, I found a not small number of studies that show higher rates actually shift the pressure-volume relationship to the left a bit. That means that a higher rate reduces LV volumes and pressures and wall stress. This reduces exposure to the exponential rise in myocardial stiffness, and it promotes early diastolic filling by a suction effect. And of course, these benefits are then transmitted to the left atrium, which then has lower LA pressure. And since cardiac output is heart rate times stroke volume, a higher pacing rate actually increases cardiac output. Okay, background fact number 4. Sitting alone, relatively uncommented on in JACC last year, is a randomized controlled trial from Spanish authors. First author, Patricia Palou, and they found that beta blocker withdrawal in patients with HFpEF improved maximal functional capacity and chronotropic incompetence. Background fact number 5. Remember the RACE 2 trial of strict versus lenient control of AFib? This trial, which included many patients with hypertension and likely diastolic dysfunction, demonstrated that a more lenient heart rate control strategy during atrial fibrillation of up to 110 beats per minute was non-inferior to a heart rate control of less than 80 beats per minute. And it was a numerical signal towards better outcomes at higher rates. Now, this isn't exactly the same situation, but maybe there is something about higher rates that benefits these patients with stiffer ventricles. Background fact number 6. Most patients with HFpEF have no class 1 indication for beta blocker use, right? Beta blockers remain strongly indicated when there is LV dysfunction and sinus rhythm. So, okay, maybe in patients with an EF around 40 to 50% there is, but other conditions that occur with HFpEF, such as CAD, hypertension, and AFib, do not compel us to use beta blockers. And finally, background fact number 7. And this may be the most compelling piece of data. My friend Sergio Pinsky, electrophysiologist, we consider him the John Roberts of EP. He messaged me that he has been taking patients with HFpEF off beta blockers for years because he's noted A, no evidence supporting the drug's use, and B, patients often feel better. Okay, now to the trial again. This group screened about 1,500 patients with HFpEF and randomized 107. So yes, that's a select group, but you had to have a pacemaker that allowed increasing rates without causing more RV desynchrony. One group got this personalized accelerated pacing, which was based on height and EF. Remember, the concept here is that whales have slower heart rates than mice. So heart rate does depend on size. Senior author Marcus Meyer did modeling studies to determine the exact pacing algorithm, which I need to better understand. But suffice to say, there were higher median heart rates in the active arm than the control arm, which was left at about 60. This resulted in a median pacer-recorded heart rate in the active arm of about 75 beats per minute versus 65 beats per minute in the control arm. These patients were 75 years old, half of them were female, they had a BMI of about 30, and most had mild to moderate New York Heart Association heart failure symptoms, and the mean ejection fraction was 60%. Follow-up was 1 year. The primary outcome was quality of life measured by the Minnesota Living with Heart Failure questionnaire. They had 4 important secondary outcomes: changes in NT-proBNP, pacemaker-detected physical activity, atrial fibrillation from baseline, and clinical adverse events. And there were 4 big results. There were substantial improvements in the ML-HFQ quality of life scores in the active arm. These easily met statistical significance, though I want to add a little caveat that there was an issue here with looking at the change from baseline rather than the change in the 2 groups. In other words, both groups improved a lot over time, and the absolute difference between the groups was less than the change from baseline. So some statisticians can weigh in here. NT-proBNP levels dropped significantly in the active arm, whereas it increased in the control arm. Patient activity measured by the pacemaker increased more in the higher pacing rate active arm, and crucially, there was less AFib noted in the higher pacing rate arm, so super positive results. So my comments are wow, wow, double wow. As always, these good studies raise specific implications, but then larger conceptual issues. Here, this small study suggests that a slightly higher pacing rate may improve patients with HFpEF, and it comports very well with the JACC paper from Spain showing that withdrawal of beta blockers improves function in patients with HFpEF. But the larger epistemic implications are huge. The entire dogma held by nearly everyone that patients with HFpEF and diastolic dysfunction, aka stiff hearts, benefit from lower rates to allow more filling, that concept may be utterly wrong. And if this is true, we have been wrong for years and years. I want to emphasize maybe here, maybe, because this is a small study from one center that needs to be repeated and replicated. But if this is correct, and some of the supporting data suggest it is, this could be on the level of another HRT or antiarrhythmic drug after MI type reversal. And in the excellent news report from Steve Stiles on the Heart.org Medscape Cardiology, he cites Dr. Michael Zeil. And Michael Zeil says, quote, "The current study basically rewrites what we know about the pathophysiology of this form of clinical heart failure," end quote. A heart failure trialist, Dr. Javid Butler, called this fascinating data and wondered on Twitter whether SGLT2 inhibitors or ARNI drugs might have been more beneficial without beta blockers. Beta blockers could be blunting the effects of these drugs. And I would say that the reduction of AFib with higher pacing rates is a major finding, and is consistent with the wall stress argument made by the authors. Reducing AFib in patients with HFpEF would be a major advance in cardiology because AFib just crushes people with stiff hearts. So the next steps clearly need to be a placebo-controlled trials of beta blocker withdrawal and HFpEF. Hopefully these are being planned this weekend. And before implanting pacers in HFpEF patients, we should surely have placebo sham-controlled arms. Some of my colleagues are rightly worried about yet another Wild West of overeager EP docs. And please, my friends, don't willy-nilly increase pacing rates because these were special pacemakers that did not increase RV apical dysynchronous pacing. This trial has only been out for a few days. I have much more to learn. I have a column in the works, but I have a sense that this is a major, major story. Next topic is MRIs and ICD therapy. The Annals of Internal Medicine has published yet another cohort study that suggests the safety of patients with non-conditional ICDs who underwent MRI scans. The short story, again, is that nothing bad happens. This was a series of about 500 to 600 patients from Johns Hopkins who had non-labeled ICDs and MRIs between the years, and sit down for this, 2003 and 2015. Johns Hopkins has been doing non-conditional MRIs for nearly 2 decades, and we struggle to do this now in 2023. Important is that patients with abandoned leads, epicardial leads, and sub-Q devices were excluded from this series. Now, I could get into the specific numbers, but perhaps it's better just to make the results simple. Of the nearly 600 patients who had MRIs, in follow-up, many of these patients had VT, VF, and SVT. They received therapy both appropriate for VT and VF and inappropriate for SVT, and the authors observed not one shred of ICD malfunction. The authors also found no direct relationship of deaths attributable to prior MRI exposure. And of course, this paper adds to the literature on the safety of MRIs in patients with CIEDs by adding long-term reassuring data on ICD device function. So my comments. The MRI and CIED story is an utter tragedy. It's safetyism run amok, bureaucracy run amok. I learned a lot about this area while writing a section of the 2017 HRS consensus document on MRI imaging in patients with CIED. The co-chairs of that writing committee were Julia Indick and J. Rod Gimbel, and I'll link to that paper in the show notes. My section was the evidence review for non-conditional devices. I made the evidence tables and wrote those narrative reviews, pages 109 to 111 in the document. Here's the thing. All, and I mean all of the studies that I found reported favorable reports for non-conditional devices. This even included studies of abandoned leads, epicardial leads, and MRI scanners with greater than 1.5 Tesla. Now, sure, all of these studies are observational, and there's single-center case series, a lot of them. But when taken together, my take-home was that as long as there was an institutional protocol and there was careful programming with informed people, MRIs can be done safely. I've written often about this in the past. The whole story felt like Sisyphus pushing a rock uphill. At the beginning, one company had a monopoly on MRI-labeled devices, and the professional societies weren't budging. They weren't incorporating the new evidence. And I'm sure it had nothing to do with the fact that this company sponsored the societies. Now, of course, all pacemaker companies have labeled devices, but there are still mixed and match leads and generators that aren't technically labeled MRI conditional. And of course, these patients can have MRIs done safely as long as there's an institutional protocol and smart programming. And if this were a medical decision, free of all this safetyism and bureaucracy, it would not even be an issue. There would be a risk-benefit analysis, and we would just proceed like we do in everything in medicine. But yet the problem persists, and journals will continue to publish more of these same sort of studies which show the same thing, that there's safety in scanning patients with CIEDs. And of course, the radiologists, middle managers will still refuse to incorporate this new evidence, and patients who could benefit from MRI imaging will suffer. And I'll tell you, a few stories in modern cardiology expose the way in which safetyism blocks a beneficial intervention. And I just get so mad and frustrated when I talk about this story. Next topic is AFib and dementia. The Heart.org Medscape Cardiology has an excellent features piece wherein Dr. Jag Singh interviews Dr. Jared Bunch about Jared's research looking into the relationship between AFib and the different forms of dementia. I highly, highly recommend you point your browser to that site and read or listen to the interview. The transcript features a trove of worthy references. You will learn a lot from this piece. Now, it doesn't hurt also that both of these doctors are some of the nicest people in our field. And of course, I've said numerous times that being nice can be overrated, but these two are really, really nice people. Here is the executive summary, and it won't do the piece justice. AFib and dementia studies are all associations at this point. We all know that AFib and dementia are associated with aging and cardiometabolic risk factors that come with aging, like hypertension. We also know that AFib can cause strokes, and so there is that association as well. And bolstering the stroke as cause of dementia idea are studies showing that patients anticoagulated early and effectively have lower risks of dementia. Now, of course, this sort of work is going to be confounded by the fact that patients who take oral anticoagulation and patients who do better with warfarin may have other characteristics that render them lower risk of dementia. But there are some other interesting clues in this story. Here's one. AFib is associated with dementia without overt ischemic injury, such as Alzheimer's type dementia. And the association here is strongest in young people, before there's time to be confounded by age-related risk factors. Why is this? I don't know, but I've practiced long enough to see many an AFib patient develop dementia at a young age. Now, maybe it's just coincidence, but maybe there's something there. There's also some interesting work on the overlap between the genetic markers that associate with both AFib and dementia. That's interesting. Bunch and Singh then offer some ideas on therapeutics. And apropos to the MyPace study that I led with, Bunch mentioned that less aggressive rate control in patients with permanent AFib may be important. He wondered whether those pauses at night that we've always ignored, because you have to ignore them if you want reasonable AFib ventricular rate control during the day, those pauses may be more significant than we thought. Now, I do want to push back ever so gently on some of the data suggesting early rhythm control correlates with lower rates of dementia. The three problems with this are, A, anytime you see non-random comparison that purports to show that successful rhythm control associates with better CNS outcomes, it's going to be biased because healthier patients are surely more apt to have successful control of their rhythm. B, the data supporting early rhythm control is much weaker than my colleagues think. For instance, the HFpEF trial found better outcomes with early rhythm control compared to standard of care. But these results are likely the result of performance bias, not AFib suppression. And the early AF ablation trials simply show that ablation is better than drugs for reducing AF, and we already know that. C, always remember that ablation causes, quote, white spots on MRI. And this is classic euphemism. and that the white spots are actually areas of brain injury due to arterial debris from the procedure. Yes, they may improve over time, but I am not sure we have adequately sorted out the long-term effects of AF ablation on cognition. So the answer is the ever-present, quote, we need more studies. But I would be more specific here. I think we need more randomized trials. As the relevance in heart rate and HFpEF have revealed, the answer is randomization and long-term follow-up. I think we're entering an era of cardiovascular medicine where it's going to be hard for any new therapy to budge outcomes like mortality because patients live so long, and when they become elderly, there are so many competing causes of mortality. So it's going to be hard for new strategies. And to me, this makes cognitive outcomes a super important endpoint for AFib and all EP trials. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating on whatever podcast app you use, or even a 1 or 2 sentence review goes a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.